So essentially, we know that CRT is one of the first line therapies now of CIED for all those patients who have systolic LV dysfunction along with left bundle branch block. There is a significant interpatient variability in the clinical response to CRT, and of course, the kind of improvement that can happen after CRT is implanted in terms of LVEF. So we have to make a lot of attempt so as to continually be made towards predicting the possible benefit to the patient at large by optimizing CRT and by appropriate patient selection. The aims of our study was to assess and identify the best predictors of CRT response using regression analysis as well as machine learning technique, and of course to derive a simple, easy to use predictive score for success without complex echocardiographic or EP techniques as you can use in a day-to-day life. We have sequentially recruited 170 patients who were suitable for CRT, who were in NYHA class 3 or 4, and with an LVEF of less than 35% with LVBP despite optimal medical therapy that was given to them. We have done routine device parameter optimization at baseline and on follow-up. We do it every 3 months initially and then 6 to 12 months afterwards, and it was all electronically recorded till the last follow-up in 2022. For the sake of this sake of this study, we have defined the patients as responders if they had an improvement of LVEF of more than 10% with an absolute reduction of LV and systolic diameter of more than 15%. Only up to a maximum of 1 year was studied after the CRT implant. That is, they should have had this within the first year of CRT implant from the implant date. We have done a separate analysis for up to 3 years, which was not part of the study, for the late improvement. The lead was implanted in the most lateral, posterolateral of the posterolateral tributaries with the best electrical parameters. QLV guided analysis was done only in 35% of patients. We have got only 10 patients who had an MRI for the scar burden. Generally, it was done on echo. And then since most patients were non-ischemic DCM, we have done an angiogram in all of them. Echo-based dysynchrony analysis was done as a study parameter, and it turned out to be actually the weakest predictor, which I'll come to later. All the parameters were registered on a yearly basis for the electronic part, or as clinically indicated. We have done both logistic regression, that is univariate and multivariate analysis, as well as ML from 3 different models, which I have written codes for as a derivative cohort. And subsequently, the cross score was generated and then validated in the next 40 patients where we have done CRT. So we have taken 154 patients, 69% were men. We had almost very, very few patients with ischemic cardiomyopathy. More than 99% were non-ischemic cardiomyopathy. We had 100% patients with LVBP with a mean duration of 154. We have put CRT-P in 65 patients, CRT-D in 89. CRT-D was put in those patients who had a documented sudden cardiac death revived or where there was a clear VTVF indication. Otherwise, we went for CRT-P. We got a positive response in about 109 patients, which was 71% positive response, And then we studied the predictors for the positive response versus those who did not have it. That is, 45 patients did not have it. Also, we did a split sample analysis in our own patients, that is 40 patients, 30 till the time we had submitted this paper and 10 more since the admission. We have got a mean age of 54 in our patients. 156, as I said, have got class 2 or class 3 on OMT, despite OMT. And then mean LVEF was 26.5 to 44%. That is the delta LVEF improvement. We had got 29 patients who were super responders, and excuse me. And then we had a mean LV and systolic dimension reduced from 62 to 51, which was also significant. In both the multivariate regression analysis and in the machine learning analysis, which I'll show next, we got one pre-implant ECG predictor, one pre-implant echo predictor, and 3 immediate post-implant ECG predictors, which were seen consistently in the responders and in the super responders. In this, when we have applied machine learning, this is called as a precision recall analysis. Is actually applied when there are less number of patients. We cannot really apply regression. Regression is not very sensitive when the number of patients is less. We need a lot of numbers for multivariate analysis, though we have done it. So what we got is the pre-implant QRS being more than 160 milliseconds, the immediate post-implant QRS being less than 130 milliseconds, and the R-wave height being more than 5 mm in V1 lead, were the ones which did the best. It was ranked as per the F1 values. F1 is the accuracy. So these accurate was 0.83, 0.811, and 0.79 respectively, as per the 3 parameters. The AUC was done for this validation cohort was around 0.81 on the logistic regression. Then we applied machine learning. In machine learning, we see the patient factor. That is, I've always said, we have to go with one factor against all the other factors. If we think in terms of logistic regression, it assumes a linearity. It need not be linear in real life. We can have multiple parameters which make a play, like interplay in the patient. So when we saw all parameters against all other parameters as n and n minus 1, it was studied as an 11 by 11 factorial. In this, we have seen that QRS of more than 170 milliseconds. We got a little different value in this with LV electromechanical delay of more than 70% of total QRS. That is, if it's a white QRS, if there's an initial LV delay of more than 70%, which contributes to total QRS, it was given a weighted score of 3. And in the absence of it, was given as -2. So it actually, machine learning gives us both the strong positive and the strong negative predictors. In terms of the R wave height of more than 5, we got a sting of 2.5, that is 5 mm in V1 immediately post CRT, as I said. Similarly, QRS less than 130 immediately post implant. Both of them, if they were there, it was scored as plus 2.5, not there, so it was -3. So the strongest negative predictors were these. If you do not get these in your immediate post implant CRT, then you are more likely to get a patient who is not going to respond. So 0.754 and 0.693 was the accuracy of this. A septal Q of more than 3, we tend to see this Q in the lateral leads, 1 and AVL. So if there was a septal Q of more than 3, again, in the immediate post-implant, it was much more likely. And it was equally negative as well, that if it is not there, then it will portend to a poor prognosis. And a pre-LV implant, if we had a LV which was remodeled to less than 60, I'm sorry, it's supposed to be more than 60. I'm sorry for this. More than 60, then it is more likely to be there. And if it is absent, then it is -2. So we got total score of either +8 or 7 and below. So when we saw it as +8 in a validation cohort, that is the 40 patients, 30 which we have sent in the paper, and 10 more after that. We had a workshop in August. So when after we have seen in those 40 patients, a score of more than 8 was actually as good as like a logistic regression. So 0.79, but we could actually eliminate a few of our predictors, like female gender, for example, was not anymore a part of analysis. It was equal for both the genders. Again, the accuracy is actually better than for the logistic regression, around 0.85. If you see in terms of a perfect classifier of what was expected, that is predicted by cross, and what was really observed in real life, it was not significant at all. So our cross score was very sensitive towards, in the forward analysis, it actually predicted success rather than not. So a simple machine learning derived 5-parameter score can be incorporated as an easy to use measure. We have not used dysynchrony. We have not used complex EP procedures in this. We have not gone for too much of QLV, though it is considered as one of the most sensitive predictors. Post-implant acute ECG responses can be easily seen by the bedside. They carry significant weightage. Every effort must be made to achieve this for the immediate and long-term clinical benefit. In terms of a simplistic score, maybe a little too simplistic. Maybe we need to see it longer term and in more patients. But it is the first such score in a varied Indian patient cohort with fairly good accuracy and predictiveness. Thank you, sir.